All right, so I've got, I guess, 10 minutes to talk about triglycerides, so I'll be quick. Relevant disclosures to this talk are research funding from Amarin and 89bio. I'm going to cover compounds that they make or are researching. So are triglycerides important? Are they an independent risk factor? Yes, is a simple answer. There's a lot of debate about there, but there shouldn't be. This Mendelian randomization from Brian Ferns in JAMA a couple of years ago shows pretty clearly that both genes controlling LDL cholesterol and genes controlling triglyceride levels, or specifically triglyceride-rich lipoprotein levels, are independently associated with cardiovascular risk. What is different is the magnitude of those relationships. That is, you need to change LDL by relatively less to influence cardiovascular risk. You need to change triglyceride levels by comparatively a lot more. So that's why I think there's some confusion in the literature. It's not the same sort of one-to-one relationship in terms of LDL and triglyceride level lowering and risk. I'm going to focus on one particular drug that happens to lower triglycerides, icosapent which is an ethyl ester of the omega-3 fatty acid EPA. Though I'll say up front that the predominant mechanism of benefit of the drug isn't from triglyceride lowering, but it's been studied in patients with elevated triglycerides. The benefits are likely due to many other things that Dr. Moran just elegantly touched on, having to do with inflammation, but pathways distinct from the ones that she showed, and a variety of other mechanisms of action having to do with influencing favorably oxidation of LDL cholesterol, effects on plaque volume, effects on thrombosis and platelet activation. The JELIS trial some years ago showed in a large randomized open label trial that there was a significant benefit of icosapent ethyl over control with concordant benefits in primary and secondary prevention, and in a trial where about half the patients actually had normal baseline triglyceride levels, though all the patients had elevated LDL cholesterol levels. More recently, actually this was just published today in Circulation, so I couldn't update the slide. That happened during the first talk, but published in Circulation's Respect EPA, previously shown as a AHA late breaker. This too is a trial of icosapent ethyl versus control, so randomized but open label, so no placebo, but it is randomized. And whether the primary endpoint was reduced or not, I guess if you're a statistical purist, it's 0.0547. So borderline there in terms of statistical significance, but the secondary endpoint was significantly influenced. And the way the curves behave, separating after a period of time, makes it look like it is a real finding, especially when viewed in the context of the other positive trials. The trial I'll focus on for this interventional audience, for some of the secondary analyses I'll show, is the REDUCE-IT trial. This was a large trial in the West. The other two trials I just showed were in Japan, randomizing patients to icosapent ethyl or placebo and looking at ischemic events in patients with modestly elevated triglycerides. And the primary endpoint and key secondary endpoint of the trial significantly reduced. Each component of the endpoint was also significantly reduced. That includes cardiovascular death, MI, and stroke. But for this audience of largely interventionalists, I'm going to focus on some of the findings pertinent to an interventional practice. In this particular analysis in Circulation showed a significant reduction in coronary revascularization with icosapent ethyl versus placebo, a hazard ratio of 0.66. Significant finding. Now, interestingly, the time to that benefit was pretty quick. By about a year, there was a significant benefit that was observed. The hazard ratio was low, below 1, right soon after randomization, but achieved statistical significance by about 11 months. So unlike some of the other endpoints, like cardiovascular death, that take a little while for the benefit to accrue. Here, the benefit on revascularization was rather rapid. And the benefits seen in the trial were seen for elective coronary revascularization, urgent revascularization, and emergent revascularization. So all categories of revascularization were significantly reduced. And this is all work that was independently adjudicated by Mike Gibson's shop in Boston. As well, there was a significant reduction in PCI and also in the need for coronary artery bypass grafting in this blinded trial. So that was the REDUCE-IT trial. Now, I'll quickly share with you some findings from EVAPORATE. That was a smaller mechanistic study randomizing patients also to icosapent ethyl or placebo. It showed a significant difference in the rates of plaque progression in favor of icosapent ethyl. But this summer, published in EHA Imaging, was actually the first demonstration ever of any drug affecting FFR as determined by non-invasive CT angiogram, where icosapent ethyl had a significant benefit. And, this is a modest size mechanistic study, but potentially in the future, even beyond icosapent ethyl, we could consider a world where we're doing phase 2 testing of compounds to look for efficacy using FFR as determined by CT, maybe even following patients over time to see if medical therapies of at least a certain sort are effective. But at any rate, the first demonstration of any drug effect on FFR CT. So let me move on now to REDUCE-IT PCI. This is the subgroup of patients with a history of PCI, about 3,000 or so of them. The prior slides were looking at the endpoint of revascularization. This is looking at the subgroup of prior PCI. And here you can see for the quintuple MACE endpoint, a significant benefit of icosapent ethyl versus placebo. Even if we look at harder events, CV, death, MI, stroke in the PCI subgroup, as in the overall trial, there's a significant benefit. But the magnitude here is pretty large. As you can see, relative risk reductions of 34%, absolute risk reductions of 5.4%. This was also true in patients with a history of bypass surgery. There was about 1,800 of those patients, so actually larger, even though a subgroup, larger than most CABG trials. Here as well, a significant reduction in 5-point MACE, as well as a significant reduction in 3-point MACE. Once more, large relative and absolute risk reductions. You see there an absolute 6% reduction in hard MACE. And finally, let me just show you this subgroup of patients with prior MI, since interventionalists take care of a lot of folks with MI and a history of MI. And this was work that was published in JACC by Prakriti Gaba from the Brigham. And here, if one looks at first events or total events, either for 5-point MACE or 3-point MACE, in all cases, large absolute and large relative risk reductions favoring icosapent ethyl versus placebo. As well, if we look at mortality and different types of mortality, this also was lower with icosapent ethyl versus placebo in the prior MI patients. You can see cardiovascular death here significantly reduced. Takes a couple of years, 2-3 years, for the curves to really start to diverge. As well, the pre-specified tertiary endpoints of cardiac arrest and sudden cardiac death were significantly reduced. They were significantly reduced in the overall trial as well, but significantly reduced in this subgroup. And once more, it takes a couple of years for the curves to really start to diverge. In this mediation analysis that was presented at the past ESC, we saw that about 2/3 of the benefit of icosapent ethyl could be attributed to EPA and arachidonic acid. Icosapent ethyl raises EPA, it lowers arachidonic acid. And about 15% of the benefit was actually due to the triglyceride reduction, and about 5% or so was due to other sorts of changes in other lipid and inflammatory markers, and about 15% of the benefit couldn't be determined by things we actually measured in the trial. All right, well, let me shift gears quickly to another approach to lowering triglycerides. There are a lot of things under study right now, but for the sake of time, I'm just going to focus on one, FGF21, fibroblast growth factor 21. And this is an endogenous stress hormone. Probably a lot of cardiologists haven't heard about it, but it actually does play a major role in both lipid and glucose metabolism and energy metabolism. And among the many things it does, it increases triglyceride uptake in adipose tissue, also ultimately has an effect on the liver and decreases triglyceride levels. So lots of different actions. But in a phase 2 trial just recently published in Nature Medicine, we saw a very large and significant reduction in triglyceride levels across the doses studied, about a 50 to 60% or so reduction in triglycerides. And we often think of the heart, because everyone in the room, I think, is a cardiologist, but this is actually an MRI of the liver. And this was an 8-week phase 2 study, but look at the liver in the placebo arm. The green means there's a lot of fat. So at baseline, there's a lot of fat, and in 8 weeks on placebo, there's still a lot of fat. But look what happens in the different treatment arms here just over the course of 8 weeks. These green livers turn blue. So the amount of fat goes down dramatically just over the course of 8 weeks. So in the future, I think as we study triglyceride compounds, we will, of course, continue to look at cardiovascular endpoints. But I think the liver is pretty important and wrapped up in all of this as well. All right, well, for the sake of time, I should wrap things up, but thank you very much for your attention.